Most appropriate management: start IM hydroxycobalamin injection, start oral cyanocobalamin supplements, start oral folic acid supplementation, provide dietary advice only, arrange for red cell transfusion. Okay. A 28-year-old woman present to her GP with a 3 months history of fatigue, shortness of breath on exertion. Okay. So 28, no, I mean young age, right? And he came with 3 months history of fatigue, SOB, and on exertion, tingling in her hands and feet. He has been following a strict vegan diet, mark it, okay? For the past, just let me choose my color. Okay, strict vegan diet for the past 5 years. On examination, he's pale with reduced vibration sensation, okay, in her lower limbs. Her blood tests show hemoglobin is low, MCV is high, WBC is okay, platelet is okay, serum vitamin B12 is low. They have given you a very good picture. And serum folate is normal. What is the most appropriate management? Give me the diagnosis first.
Acute combined
Megaloblastic anemia.
Again, one by one.
Acute degeneration of
the core.
Somebody told megaloblastic anemia. Agreed. Megaloblastic anemia due to what?
B12 deficiency.
Very good. Vitamin B12 deficiency. Because of what?
What she said?
vegan diet.
Veg diet. Very good. Strict
Vegan diet.
vegetarian. Because they're strict vegan. That's why there is vitamin B12 deficiency. From dietary source, they are not getting the vitamin B12 more. That's why there is deficiency. And that's why there is megaloblastic anemia. Very good. So that's why neurologically, so vitamin B12 deficiency, what they're doing, whenever vitamin B12 deficiency is there, they can do okay, hydroxycobalamin. Okay, I am agreed. Hydroxycobalamin you want to start. Why not cyanocobalamin? It is also vitamin B12. Agreed?
Yes.
Both are vitamin B12. Why not cyanocobalamin?
We start with injections.
Sorry, I cannot hear. It is
We start
oral.
with injections.
Because
Very
this is
good.
oral source.
Oral source. Very good. Oral will take time. Rather, we are choosing the IM source. Okay? So, if that's why this one is not, it is not about the cyanocobalamin. Both are vitamin B12, trust me. So, if it is IM, choose for that one. You need to treat it intramuscular. Oral will take time, and even it will, not maintain that much vitamin B12. So that's why we are treating the vitamin B12 deficiency with intramuscular injection. That's why we have started that. Okay. Folic acid sometimes as a supplementation. If we see folate is low, we can go for that. But here serum folate is normal. So it's up to you if you are giving it or not. It doesn't matter because folate level is normal here. Provide dietary advice only. Dietary advice, it will take a long time because already he's having so much megaloblastic, and not only that, he's neurologically also affected. Agreed? He's having reduced vibration sensation. Why? Which tract is affected? Which column?
Dorsal column.
Dorsal column. Very good. Dorsal column affecting. If dorsal column affecting, which one will go? Vibration and
Position.
proprioception. Very good. So that's why. So whenever our vitamin B12 deficiency is there, see, vitamin B12 deficiency, what they can do? They can do so many things. They can do anemia, megaloblastic, right? They can do our spine tract, long tract, they can affect it. Even they can do in the peripheral neuropathy, even they can do, right? They can do peripheral neuropathy, and even in the brain, they can do mood disorder, memory loss, they can do all. So in spinal tract, what they can do? They can affect the dorsal column, like this patient. If dorsal column affected, this is the subacute combined degeneration, right? SCD, subacute combined degeneration. So SCD, what is happening? Three tract will be involved. What happened? They can involve the dorsal column, and they will miss what? Vibration and proprioception, right? Very good. There will be lateral
lateral column,
corticospinal tract. So this one, what will be? Here is the mixed. This is our mixed lesion. Upper motor with ankle reflex absent with lower motor neuron. Right? This is one of the cause. If you remember, upper motor and lower motor combined, one of the cause is our SCD, subacute combined degeneration. Agreed?
Yes.
Okay. And not finish, still spinocerebellar. If spinocerebellar, it will affect your gait. It is happening with ataxia, sensory ataxia. So this is your combined degeneration. So you see, whenever vitamin B12 deficiency is there, it can do so many things. It can, in your body, it can make anemia, or it can affect your brain, the main brain, to mood disorder, dementia, confusion, okay? And last but not the least, the most important, it can do subacute combined degeneration, okay? This patient having both. He was having anemia. He was having also subacute combined degeneration, one of the component they mentioned, vibration, okay? So whatever it is, if they're asking only vitamin B12 deficiency, treatment is same. Subacute combined degeneration, treatment is same. Because cause is the main. Cause is vitamin B12 is not there. You need to provide the vitamin B12. That's it. If something is deficient in your body, you need to give it. You need to give it in such a way that it will work very rapidly. And the very rapid way is intramuscular, not the oral. Okay? This is your takeaway message. Okay? So that's why we are not giving for oral. But remember, hydroxycobalamin, cyclocobalamin, even cyanocobalamin, you can give in a IV route also. So hydroxycobalamin only in IM, only injectable, not IM, injectable form only. Cyanocobalamin you can get in oral, in injectable. So don't be confused if you see maybe in your exam, maybe you will see that they didn't give you this one. They have given you start IM, cyanocobalamin. Answer will be same, this one. Because IM, you need to check if it is vitamin B12 and the route is intramuscular. Is it clear? Clear?
Yes, it's clear.
Okay. Okay.
Can I ask a question? Sorry.
Yes, please.
If, for example, the folate was low, which one do we correct first? Is it the folate or the vitamin B12?
Vitamin
B12
B12.
was
B12 should be first. And then,
Paris.
otherwise it will precipitate more your subacute combined degeneration. Okay? So B12 deficiency you need to correct first. Okay, very good question. Thanks for your question. Okay, this is also coming. They will give you like this. You see here they have given you oral folic, but we have chosen the vitamin B12 deficiency. So this is the answer. Okay, thanks for your question. I want you guys to ask me. Okay, I am also learning with you guys, right? Okay, Dr. Muna has written B before F. Yes, because if you are giving folate, maybe it will precipitate your SCD more, subacute degeneration more. It will be worsening. So better to that B12 deficiency, correct it first. Okay. And I think she mentioned B is alphabetically before, right? Like that, yeah. B is first coming, yeah. And F is later on. Yeah, very nice. Okay, so I'm not going to read it. Already I have told more than this explanation to you. Okay, what is the most likely diagnosis? If you guys want me to slow down, please tell me. I'm taking you, all of you, as you have already done neurology and we are doing brainstorming. That's why I'm a little bit hurry I'm doing. Otherwise, we cannot finish, okay? So I want to do more questions so that you will know more. Okay, so let's go to the next one. What is the most likely diagnosis? Myasthenia gravis, Lambert-Eaton, myasthenic syndrome. This is our LEMS, right? LEMS. Then polymyositis, MND, motor neuron disease, Guillain-Barré syndrome, GBS. Okay. 68-year-old man. He's very old. 68. Okay. Now, he came to the neuro clinic and I want it a little bit dark color and okay. So he came to the neuro clinic, 3 months history of progressive muscle weakness. So there is muscle weakness, okay? He reports difficulty climbing stairs and getting out of the chair. Why they're telling this? Difficulty climbing stairs. What did I tell?
Proximal muscle weakness.
Very
Proximal
good.
muscle
This is
weakness.
proximal myopathy. Very good. Or muscle weakness. Whatever you told, both are same. So this is your proximal myopathy. Okay. And if it is in the hand, how they will tell?
Can't comb their, can't
Yes.
reach
Comb
the
hair.
Can't comb
upper.
their hair or can't elevate their hand over their head like that, right? Very good. Excellent. He has also noticed that his symptoms improve as the day progresses. Okay, so day progresses, his symptoms is improve, not worsening. Look at it. Okay, he has 45 pack-year smoking history, has lost 6 kilo in weight over the past 2 months. On examination, he has proximal muscle weakness. In the history, they have already mentioned that. Now they mentioned the diagnosis, diagnosis also. More pronounced in the lower limbs than in the upper limbs. Reflexes are initially absent, hyperreflexia, but become more pronounced. That means reflexes are coming. Somebody has background noise. Okay. And become more pronounced with repeated testing. Okay. Cranial nerve examination is normal. Can you please be careful? Some background noise is there, dear. So please be careful because difficult for others also to listen. So cranial nerve examination they have done, it is normal. Chest X-ray reveals a hilar mass. Give me the diagnosis of this hilar mass.
Small cell.
Small cell.
Very good. This is the small cell.
Lung cell carcinoma.
Lung carcinoma.
Lung cancer.
This is the small cell or squamous cell.
Small cell.
Small cell.
Small cell.
This is the
Small cell.
small cell carcinoma. They have done why? Why there is the problem?
Paraneoplastic syndrome.
Very good.
Phenoid?
This is the paraneoplastic syndrome. Very good.
Lambert-Eaton.
Lambert-Eaton myasthenic syndrome. So why it is not myasthenia gravis?
Improve through the day.
On the day progresses, right?
Very good. It will be worsen. It will be not
Worsen.
improve. As the day progress, he will be more weaker, right? And with repeated testing, reflexes, it initially like this hyperreflexia usually not they are getting. Okay, in MG, in myasthenia gravis. Okay, why it is not polymyositis? There is proximal myopathy. Polymyositis, why it is not?
But in the hands, it should be the forearm muscles that are involved.
Not only forearm muscles. No, that is you are telling forearm muscles, not
Okay,
that
was
is inclusion.
body. Right,
That
it
was
is
inclusion.
body. Sorry.
Okay, that is different. So polymyositis, if I'm telling you pain plus stiffness plus weakness, it should be there, right? And there will be nothing like this this type of cancer history would be there. Okay, so there will be pain. At least they will mention about pain. And also the difficulty they have mentioned because of the weakness, but they didn't mention about pain and stiffness also they didn't mention. These are the clue for polymyositis. Okay, pain, stiffness, and weakness. Only pain and stiffness, give me the diagnosis. Muscle pain and muscle stiffness.
Polymyalgia rheumatica.
Very good. Polymyalgia rheumatica. So it is polymyalgia rheumatica, pain and stiffness. Whenever you are adding weakness, it is your myositis, polymyositis. Okay. Only pain, tender point, no stiffness. What is that? Muscle pain. Very good. Fibromyalgia. Chronic fibromyalgia, right? So chronic fibromyalgia, they will give you only pain. Then PMR, they will give you pain plus stiffness. If it is polymyositis, they will give you weakness. This will be a plus point. And there is an overlapping issue. There can be sometimes in your history. What is that overlapping issue? With PMR, you will search for always that one in the eye. What is that?
Joint cell arthritis.
GCA, very good. Joint cell arthritis. There can be overlapping. So in your scenario, it can be there with eye blur vision of the eye also. It can be there. Okay, anyway, we jumped to rheumatology. Sorry for that. But concept should be very clear, and it has to be your muscle memory. Once you see the question, you have to jump to the answer. Okay, so this some tricks are there that it has to be your muscle memory. Okay, repeatedly you should listen. Okay, so let's go. So from where we go? From the option polymer. So it is not MND, of course not. It is not our MND. GBS, there will be what? What kind of paralysis would be there? Upper motor or lower motor?
lower
Lower motor, and that will be in a
Ascending.
ascending way. Lower limb will start and will go up. So, and there will be a precipitating factor also, maybe a diarrhea or any infection. Okay, so I hope it's clear. This question clear? Can we move forward?
Yes, ma'am.
Yes.
Okay. Yes, dear. Yes, please ask.
No, I said yes, it's clear.
Oh, okay. Thank you. So I'm not reading the explanation. We have already discussed. Reading is not my style. Okay. So which is the following of the is the most likely diagnosis? Chronic progressive external ophthalmoplegia, myasthenia gravis, oculopharyngeal muscular dystrophy, multiple sclerosis, Guillain-Barré syndrome. Okay. Now, 40-year-old man, let me take my pen. Okay, 40-year-old man, this is middle-aged, present with progressive drooping of eyelids, okay, and difficulty moving his eyes in all direction. Whenever it is all direction, it's mostly ophthalmoplegia. All direction, they cannot move in any direction. He also complains of muscle is weak, exercise intolerance. His mother had similar symptoms. Okay, his mother, okay. Now, on examination, there is bilateral ptosis and external ophthalmoplegia. As I told you already, they mentioned you in how to diagnose ophthalmoplegia. They cannot move eyeball at all, okay? Eyes at all, okay. Now, lab investigation revealed lactate level is high. Muscle biopsy showed ragged red fiber. Okay, for you guys, part 1 people, it will be a little bit tricky question, but part 2 people, this is a very, you guys should know about this one. Part 1 people, tell me, if you see in your muscle biopsy, don't look at the options. Give me one answer from the muscle
Mitochondrial
biopsy.
disease.
Very good. Very good. So if you see ragged red fiber, this is your mitochondrial disease. So exclude others, you will get your answer. Okay? Because and you see also mother is affected. Look at the history. Also it is supporting the family history. They didn't tell you the father. Okay? So when you see the muscle biopsy along with this mother, you are definitely sure this is your something mitochondrial disease, maternal inherited, right? Okay. Now you cannot find any. I know you guys cannot find any option similar that you have read. Okay, don't worry. We will exclude and we will reach the answer. This is also another way. Okay, let's go with the last one. Is it Guillain-Barré syndrome?
No.
No way. Right? No way. There is no, they didn't tell that it has started with the lower limbs, then going up, and any history of any infection or any diarrhea previously. Nothing. So obviously, you know, this is not your GBS. For finish. MS, multiple sclerosis. They should tell you multiple, also MS, they must give you multiple events, right? Maybe they will give you one time muscle weak, one kind of stroke. Then another event, they will give you some eyes problem. Okay, another event. I mean, different times they will give you attacks, different attacks. They didn't mention, right? They didn't mention like that. That previously also he's having recurrent different attack. So this is also not your multiple sclerosis. Khalas. Okay. Now come with oculopharyngeal muscular dystrophy. So muscular dystrophy usually oculopharyngeal, they told. Okay, this one is also new for you guys. And chronic progressive external ophthalmoplegia. These two are new for you guys, right? Myasthenia gravis. Can it be myasthenia gravis? Is myasthenia gravis maternal mitochondrial disease? Or they have told you this muscle weaken is more prominent at evening? No, right? So this is not, but there is drooping of eyelid. I agreed. There is drooping of eyelid is there, but not diplopia. They didn't tell you that this is more at evening. They didn't tell you like that. And also lactate and this muscle biopsy is already excluding your MG. Agreed? Have you ever read that lactate is high in MG anywhere else? Have you read it? You haven't read it, right? That lactate is high in myasthenia gravis, right? Myasthenia gravis, what we are doing? Investigation?
Acetylcholine.
Acetylcholine.
Or anti-mask.
Okay, or antibody. The antibody we are checking, right? We are checking antibody. That is giving you that, yes, this is your myasthenia gravis. So there is no role of lactate or muscle biopsy is not giving you any identification of your MG, right? Okay. So now come with the another two. There is oculopharyngeal muscular dystrophy. Okay. So muscular dystrophy, usually whenever the dystrophy is there, muscle should be like weak rather than, muscle and here they told oculo and pharyngeal. Okay. So oculopharyngeal, usually this one is not your mitochondrial. Oculopharyngeal is not your mitochondrial. CP, this is actually part 2. That's why for you guys a little bit it will be difficult for you guys. Okay. And this one, what they're having problem, pharynx. So whenever you are confused that what is this, go with the nominal, the name. There has to be ocular dystrophy. There is something ocular I can find. There has to be pharyngeal muscular dystrophy, pharynx dystrophy. What you will get? What will be the symptoms? There will be difficulty in swallow, right? Swallowing. Is there anything with swallowing?
No.
Nothing, right? No swallowing. So from the name, even if you don't know, even if you don't have, because this is actually a rare disease. This is just a DD to exclude. So you can exclude from here. So the only thing remaining is CPEO. This is actually one kind of mitochondrial disorder. Okay. So your answer is CPEO. In this case, this is a mitochondrial disorder. You will have maternal inheritation. The muscle biopsy will be the same. Mainly eyes are involved. Okay. Obviously, muscle weakness also you can see. Okay. So this is another way that even you don't know, don't expect, expect that all the options in your exam will be similar, will be known to you. No, never ever think of that. So 2 or 3 options, they will give you rare disease. Even if you have, even I haven't heard, even you didn't have it heard, hear or listen or even read anywhere. Something very rare condition, they will put as DD. So don't get confused, don't get biased. Your answer is not that unknown. If it is unknown in between like this, both of these were unknown, go with the nominal, the name, what they are telling. Okay, so oculopharyngeal, it has to be with eye and pharynx. They didn't give you any topic or any idea about pharyngeal dystrophy or weakness, no difficulty in swallowing. So obviously another one, it should be there. But anyway, already now you guys know. Next time, inshallah, if CPEO, if you see, you know the topic already. Okay, clear? Part 2 people, if you are here, this is also important for you people. Okay.
Yes.
One question, ma'am.
Yes, dear.
Ma'am, if the MELAS is one of the options, so this could confuse me. Which one? Is it
they will not
CPEO
give you
or
both
MELAS?
together. If MELAS is there, yes, lactic acid acidosis there should be, right? There should be lactic acidosis, vision problem
Exactly.
also you can see. Here also lactic level is high. Yes, it could be also MELAS. It could be also MELAS, dear.
But
they're
in
having
MELAS, there should be stroke-like
hearing loss, stroke. Yes, there should be encephalomyopathy type of feature, right? MELAS means what? Go with the, again, the name. What is MELAS? Mitochondrial, that encephalomyopathy, right? Encephalomyopathy, lactic acidosis, and there would be what? S for stroke-like syndrome. Stroke-like syndrome, right? So what you will have, at least there should be some stroke feature, at least There should be encephalomyelopathy type feature. I mean, something even they can have with hearing problem. Okay, they can have headache because of this lactic acidosis anyway, but stroke-like episode they can have because of this encephalomyelopathy. Maybe they will have memory loss, dementia, mood problem. Okay, so all things will be there. Okay, so
thank you.
and they will not give both together very, very close, obviously. You can find it, inshallah. Okay, dear?
Thank you, dear. Thank you, ma'am.
Okay, welcome. Very good question. We have also revised our MELAS. Okay. There is another one, no? Carnes-Sayre syndrome. That is also coming. Can you tell me what is Carnes-Sayre? I am.
Okay.
I maybe misspell. Carnes-Sayre syndrome. This is also mitochondrial, right? Agreed?
Yes.
This is also mitochondrial. What you will get in Carnes-Sayre?
Ocular.
External ophthalmoplegia.
Ophthalmoplegia, okay. Something
Cardiac
black.
conduction
Something
defect
black you will see in the eye.
retinitis pigmentosa.
Very good. Retinitis pigmentosa, one of the cause.
Ptosis, external
Very good.
ophthalmoplegia.
External ophthalmoplegia. So there will be progressive external ophthalmoplegia. This is the same actually. PEO. This is one of the component of Carnes-Sayre, that CPEO. When it is chronically present, that is, it is a part of Carnes-Sayre actually. So along with that, heart also affected, right? What you will get in heart?
Cardiomyopathy.
Conduction defects.
Conduction block will be there. Heart block will be there, right? And least but not the least, they can have also diabetic, even hearing problem. Okay, they love Carnes-Sayre syndrome. Okay, yes, Dr. G, there are some heart symptoms, that is heart block usually they are having. Okay, even cerebellar ataxia, so many things they're having cerebellar. For you guys, which are the red topic that, I mean, at least some heading that you have to remember, right? PO, progressive, this external ophthalmoplegia. I mean, this eye-related all problem. It could be ptosis, it could be external ophthalmoplegia, it could be retinitis pigmentosa. If retinitis pigmentosa, how they will give you in symptom? It's a tunnel vision, right? It's like tunnel vision. They cannot see sight. Just only this black inside they can see. Like a tunnel they can see, but periphery they cannot see. So retinitis pigmentosa, they will give you this type of symptom. Okay? So they can have retinitis pigmentosa. So eye problem, retinitis pigmentosa, obviously this one you have to remember, and heart problem. They will obviously give a heart block, or they will give you a ECG mentioning that there is first degree, second degree block. These two is enough along with the maternal history. For you guys, that is enough. Even if you forget hearing problem, diabetic mellitus, it is okay. If eye problem, if you see some heart problem, along with that mother or the aunt was having the same, maybe he's adopted, or the maternal side somebody was having, and the red ragged, so red ragged fibers means obviously this is your mitochondrial disease. Okay, inherited mitochondrial disease. Clear, dear? So eye and heart, please don't forget. For Carnes-Sayre, at least these two, even if you forget everything, these two is very important. Otherwise, you cannot reach the diagnosis. Okay, you need to reach the diagnosis, right? You don't need to remember all the symptoms, but you need to reach it. You need to pick it up somehow. Okay, so that's what is happening here. What is this done? Okay. Clear? Can we go on? Can we move?
Yes.
Yes or no? Okay.
Yes.
Okay, so let's do. Okay, so what is the most likely cause of his tremor? Neurotoxicity due to elevated cyclosporine level. Okay, it could be cyclosporine can cause tremor, right? Cyclosporine, tacrolimus, all this kind of immunosuppressed drug, they can cause tremor. Essential tremor. Yes, this is a kind of autosomal recessive or dominant. Essential tremor.
Dominant.
Very good, very good. So essential tremor, they must give you a father or mother is affected. Okay. Side effect of prednisolone therapy. Okay. Azathioprine induced myelotoxicity or onset of Parkinson's. Okay, let's see what they have given. The Parkinson's also, they can have tremor. What kind of tremor? Intention tremor, resting tremor, postural tremor.
Resting.
Resting is more prominent. Very good. If advanced, all kind of, but usually resting is the first thing. Okay. So 45-year-old man underwent a renal transplant 3 months ago and is being maintained on prednisolone, azathioprine, and cyclosporine. So they are on immunosuppressive drug. I told you, any kind of transplant, it
Dr. Tania, I think you are muted.
Hello. Is my voice clear?
Yes, ma'am. Now,
Somehow it was interrupted. Net was gone down, right? Okay. Where I was telling, I forgot.
transplant.
What? Yes. So any transplant, you have to make their immune system low. So you have to give some suppressant drug, immunosuppressant drug, and that is what they have given. The same thing they did. They did a renal transplant, a new kidney, and after that, what they have done, they have given some medication to make it low immunity system so that it will not reject that new kidney, right? So now let's read what they're telling. Okay. He presents with a fine tremor in his hands that has been progressively worsening over the past 2 weeks. He denies any other symptom. Okay. On examination, his vital signs are stable. Lab investigation reveals the serum creatinine is 150. It is high. Cyclosporine level is elevated. So if you don't know that cyclosporine is a cause of a tremor, it will be very difficult for you guys to pick it up, right? Right? Is it essential tremor?
No,
Can it
no.
be? No way, right? 45 years and they didn't give you any history. And even worsening factor, then improving factor, nothing they have given you. Okay, essential tremor. What is improving?
Alcohol.
Improving with very good.
Alcohol and
Very good. Alcohol will improve, right? Now, what it will worsening?
Yes.
Stress, very good. Stress, smoking, these all can make it worse, right? Okay, very good. So we finish our. Okay, what's the treatment? Let's finish it. What's the treatment?
beta blocker.
Very good.
Propranolol.
So BT, somebody has essential tremor, he's asthmatic. You should go for
Primatol.
Primidone. Very good. In that case, propranolol you cannot use. Okay. So most of them from treatment, from essential tremor, they are giving with asthma. So that you will not use that. You will go for the Primidone. Just a minute. My kids are shouting. I tell them to stop a little. Okay, guys, I'm back. So we finish our essential tremor. Most of the cases, they are giving essential tremor asthmatic patient because they don't want you to make your answer right. They want you to make it wrong, so that next time you come again, you give money, you register again. Okay. So that is where the twist. You know everything, but you don't know how the questions are coming. You don't know where your eyes should put more emphasize. Okay. So this is the way. Okay. So next, what is that? Side effect of prednisolone. Prednisolone is not usually doing any tremor, right? And as it could be salbutamol. Salbutamol can cause, but not prednisolone usually. Azathioprine induced myelotoxicity. Myelotoxicity also azathioprine, not tremor like this. Okay, and they have given you already. They have given you a clue. The cyclosporine level is elevated. So if you know that yes, cyclosporine can cause this type of tremor, then you know the answer. Okay, dear. So they have given you supportive evidence also that cyclosporine level is elevated. So answer is, what is the answer?
Neurotoxicity due to
Very
elevated
good. Due to elevated cyclosporine. Okay, so this is your answer. So even with cyclosporine, you have this type of question. Even with tacrolimus, you will get same type of question. Okay, both can cause tremor. Okay, dear. So we finish this one. Shall we move on? Yes.
Yes.
Okay. Okay.
Yes.
Okay. Now, what is the most likely diagnosis? Bell's palsy, sarcoidosis, multiple sclerosis, Lyme disease, Guillain-Barré syndrome, GBS. Okay. 28-year-old woman present with sudden onset of left-sided facial weakness. Okay. Just okay, sorry. So present with left-sided facial weakness. Okay. So there is left-sided facial weakness. Where is this? Okay. She reports difficulty closing her eyes. So she cannot close her eyes, and there is drooping of the left side of her mouth. She also mentions dry eyes, dry mouth. On examination, there is left-sided lower motor neuron facial nerve palsy. I was going to ask you that it is upper motor or lower motor. They have already given you because the forehead is affected, eyes are affected. So this is your lower motor neuron lesion. Okay. So if it is left-sided lower motor neuron facial nerve palsy, which side is affected? Left side or right side? I mean, this is left lower motor neuron lesion or right-sided lower motor neuron? Which part of the brain is affected? Same side, ipsilateral or contralateral?
Ipsilateral.
Okay. Ipsilateral, same-sided lower motor. And if it is opposite side, that is your upper motor. Upper motor. Okay. Upper motor, you write this. If it is full, this full side gone. This is the full side gone. If it is left side, that means the left side brain affected. It is ipsilateral. Okay. But if it is like this much only, the forehead is not affected. The lower part of the face is only affected. Mouth deviation is there. Weakness is there. That means if it is in the left, you will tell right-sided upper motor neuron lesion. Got it? So opposite upper motor neuron, but same side, ipsilateral lower motor. So this one is having left-sided problem. Okay. Now let's go to our question. So now affecting both the upper and lower part of the face, left-sided, left lower motor neuron lesion. There are no other. Somebody has some background noise. Please take care so that everyone can get the benefit. Okay. There are no other neurologic. If you are opening two devices, please stop one. Otherwise, this type of background noises are there. It is a request so that everybody can have the best benefit, the most one. Okay. Thank you. Thank you so much. There are no other neurological benefits. Deficits, sorry. Benefits, deficits. Her past medical history is significant for uveitis. Okay, he's having red eye. Uveitis is there. Now, blood test reveal serum calcium level is high. It's a question. Be very, very, very concentrative. Okay. ESR is high. ACE level is high. What is the most likely diagnosis? there is bilateral, left-sided lower motor neuron lesion. Okay. So they have given you some other features also, like calcium level high, ACE level
Sarcoidosis.
high. Very good. Very good. This is sarcoidosis. And that's why the sarcoidosis is the cause behind this facial nerve
Facial
palsy.
palsy.
So it is not Bell's palsy. Why not? It is idiopathic. They don't have any cause. When there is no cause, but facial nerve palsy, we are telling this is Bell's palsy. Agreed?
Yes.
Okay. But here there is a cause.
Yes.
There is a cause behind this facial nerve palsy. There is facial nerve palsy. No doubt about that. He has left-sided lower. They have already mentioned that he has left-sided element facial nerve palsy. But the cause is not Bell's palsy, because Bell's palsy, whenever we don't find any cause, we are declaring, okay, we are idiot. We don't know about your cause, idiopathic cause. You are having Bell's palsy. That is why we are diagnosing it as Bell's palsy. So this is not your Bell's palsy. They have given you a cause, a scenario behind. Background, there is a disease. Okay? So it is your sarcoidosis. Obviously, this is not your multiple sclerosis, serum calcium, ACE level, it will not be high. Lyme disease. What is Lyme disease? From where it is coming?
Bite. Tick bite.
Tick bite. Tick bite. Borrelia, right? Borreliosis.
Right.
Even Lyme disease with lower motor neuron, they can also cause facial nerve palsy.
Yes.
Okay, they can also cause. But here they didn't give you a mountain high history. They didn't give you that he had a tick bite. They didn't give you there is a rash with like this erythema. What is this called?
Erythema
migrainous, right? So you don't have anything, any history of your Lyme disease. So this is also not the cause. But yes, Lyme disease can also cause facial nerve palsy. And you have question from this. So you need to know that facial nerve palsy, it can happen from any cause. I mean, not any cause. There are some causes, and you need to know that how these scenarios are coming. So as I told you, with Lyme disease, you will have question. Okay. With GBS, you will have question. GBS also, they can come with facial nerve palsy. With Lyme disease, you will have question. With sarcoidosis, like this question already you have come across. Sarcoidosis also as a background cause of facial nerve palsy, I'm telling. Are you getting me or not? This all as a scenario of facial nerve palsy, they will give you. They will give you facial nerve palsy on a background sarcoidosis. Like this question. Facial nerve palsy in the background of GBS. Facial nerve palsy in the background of Lyme disease. So all the options here, actually, you have question and exam question. It is coming. So you need to understand.
Neuroma also.
Yes, acoustic neuroma. That is also, it can come. Okay. Even varicella zoster virus. From there also it is coming. Right? Usually Bell's palsy, we are telling herpes simplex virus. But idiopathic, mostly idiopathic we are thinking. Okay. So yes, so many causes are there. Okay. Even diabetic can cause, but you don't have this much deep. Only this type of scenario, as I mentioned, you will get. Okay, dear? If you have, what is that? With painful vesicle, what you will think? In the ear. In the ear, you will have painful
syndrome.
Very good. Ramsay-Hunt syndrome. That is from varicella zoster virus, right? So that is also coming. Facial nerve palsy from varicella zoster. How you will find it out? There will be painful vesicular rash in the auricle, in the ear, behind the ear, or in the auricle. They will tell like that. Clear how it can come, the facial nerve palsy? Yes or no? If any confusion.
Yes,
thank you. Thank you. Okay, so let's go. Medicine is fun, dear. If you understand each and every line, that time you will find it very, very nice. I mean, very funny and very entertaining. Okay. Okay, let's go. What is the most appropriate initial management? Oral prednisolone 50 mg daily for 7 days. So I always ignored the dose because dose is not important for you guys. Oral prednisolone, oral acyclovir, oral prednisolone plus oral acyclovir, observation and reassessment in 72 hours, urgent MRI brain scan. So let's see. 34 years old woman present to the ED with a 12 hours history of right-sided facial weakness. So there is right-sided facial weakness. Okay. He noticed it upon waking this morning. So suddenly it started. Has been unable to close her right eye completely. Okay, again like facial nerve palsy. She also reports altered taste and pain behind the right ear that began yesterday evening. On examination, she has a complete right-sided facial weakness affecting both the upper and lower face. Okay, there is no rash or vesicle in the ear canal, but there is a pain. Her neurological examination is otherwise normal. So this is what, give me the diagnosis first. This is Ramsey-Hunt. Very good. Already we have discussed. Okay. Now the trick things is how you will diagnose. I mean, treat.
Oral prednisolone and oral acyclovir.
Okay.
Prednisolone plus acid.
Okay. I was expecting this. Okay. Yes, we are giving both together, but nice guidelines. What they're preferring actually prednisolone alone first. Initial, you can start. Later on, you can add oral acyclovir. Okay? So if they're asking you initial, go for this question answer. If they're asking you only management, you can choose this. Is it clear? They're telling to start with prednisolone. Later on, you can start acyclovir if it is not improved. Okay? But when initial, this word is there, please just choose prednisolone rather than the combination. Clear, dear? Clear? Yes or no? Okay. So that's why. So see here, combination therapy with oral prednisolone acyclovir not routinely recommended at first line in Bell's palsy in UK, while some international guidelines suggest considering combination therapy. Even in UK guidelines, they're telling you can add later on. So it's not like that they are not adding. They are adding. But because of this only one word, initial, you need to choose prednisolone. But if they didn't mention initial, please go for both. No problem. If you know that it is from viral. But if they're giving you like no auricle, I mean, no painful vesicle, maybe only Bell's palsy, no cause is there. Obviously, you will not add acyclovir, will you? It is not viral. You are not sure. Bell's palsy is idiopathic mostly. So in that case, you will not mention oral acyclovir, of course. But here there is suspicion, though they are told that there is no vesicle in the ear canal, but they told pain behind right ear. So it could be mostly Ramsey-Hunt syndrome, mostly coming with post-auricular pain, right? Okay. Is it Bell's palsy or Ramsey-Hunt? So this is the point. Bell's palsy, they can have also pain behind the ear. So Ramsey-Hunt actually better if you don't see vesicle for your part 1, you people, if you don't see any rash from varicella zoster, or if you don't see any vesicle mentioned, better you diagnose this as Bell's. So better I will choose this as Bell's palsy, because they told actually there is no rash. Okay, dear? Clear or not? Ramsey-Hunt for your part 1, just remember they will mention either any rash in the body or vesicle in the auricle. Okay, they will not complicate. They will directly mention. But here, as they mentioned already that there are no rash or vesicle in the ear canal, they are taking it as Bell's palsy rather than Ramsey-Hunt. Okay?
Dr. Tania, in Ramsey-Hunt, do we also start with just prednisolone?
Yes, and acyclovir. Prednisolone always starting. Any facial nerve palsy, whatever the cause, your first treatment is prednisolone, even if it is from sarcoidosis. Now tell me, sarcoidosis, usually treatment is what? Very good question. Let me ask you another tricky question.
Steroid.
No, if sarcoidosis, no complication, what is your treatment? No treatment. If only complication. Now, let me see the complication. If heart involved, if eye involved, if neuro involved. Here you are involving neuro. So what will be your treatment?
Steroid.
Prednisolone, steroid. See? So that is why they mentioned like that. The sarcoidosis with facial nerve palsy, that means sarcoidosis with neurology involvement. Clear? So you have to start prednisolone. Clear, dear? And
So, ma'am,
yes, dear.
For Bell's palsy and for Ramsay Hunt, for both we start with oral prednisolone. But if it's Ramsay Hunt, then we can add acyclovir
later on. Even in Bell's palsy, sometimes they are adding. But for you guys, no need. For you guys, forget about adding acyclovir in Bell's. So just remember about this one, about Ramsay Hunt, to start with acyclovir. Better.
So in this question, it says that there are no rash of vesicles. If we consider it to be Bell's palsy, our answer remains the same as oral prednisolone.
Prednisolone only, yes.
And even if we say that it is Ramsay Hunt, it still remains the same.
It still remains the same because initial they have asked you.
Got it. Thank you.
Right? So initial they have asked you. Okay. So clear, dear?
Yes, ma'am.
Okay. So can we go later on? So see, everything sensible. Sarcoidosis, only we are giving prednisolone when it is with complication. And this facial nerve palsy is a complication. That's why we are starting prednisolone. So all are interconnected with each other. Only you need to pick up the lines, that how you are connecting them. Irregular. Okay? Like a wave. Okay? But they are interconnected. Okay. Okay. We will go for. So see here, all patients with a Bell's palsy should be given oral prednisolone within 72 hours of onset. Okay. So you have to start as early as possible. Start this prednisolone. Okay. If Bell's palsy, even with any facial nerve palsy, even if it's from GBS, or even it is from sarcoidosis, or from diabetes mellitus. If we see facial nerve palsy, actually the first thing is we are starting with oral prednisolone. This is the basic treatment. And also some other treatment is there, like eye. You will take care of the eye, right? Because they cannot close their eye. So what happened? Look here. I will also unable to close her eye. And they are having, that's why if you cannot close the eye, what happened? Eye will be dried up, right? So it will be gritty sensation. If you are opening your eye for a longer time, you will feel you are having some gritty sensation in your eyes because of the dry eye. Okay. So this patient also we are telling to put cover when you are sleeping. Maybe in the sleeping he cannot manage. It is always opened. So that time dry eye can happen. So this can have even keratitis. So complicated it can be. So that's why another treatment is supportive eye care, any lubricant, covering of the eye, and also some physiotherapy, some facial muscle exercise we are advising so that it is improving earlier along with the prednisolone. Clear?